Welcome to Section 7 in Neurology. In this section, we will be discussing audiology and balance through the vestibular system. So let's get started. So let's first talk about auditory transduction. Now, it's not going to help you to just read this out to you. However, we want to provide you with a thorough textual version of this pathway so you can refer back to in your text. But for now, let's just draw it out on a new slide. This is figure 8.33 from your text, showing the first portion of auditory transduction. So as you can see, sound waves will enter the auditory canal in the outer ear right here and cause the tympanic membrane to vibrate. The auditory ossicles, the malleus, incus, and stapes, will then transfer the vibration to the oval window. So now we're going to focus just on the cochlea. So right in here, we're just focusing on the inner ear. We've passed the outer ear and the middle ear. If we take a cross section of just one canal within the cochlea, like this, we would get figure 8.34 from your text. So now we are within the cochlea. When you see this figure, picture any point along the cochlear spiral. So movement of the oval window will cause the perilymph within the cochlea to shift. Perilymph is within the scala vestibuli and the scala tympani. So the perilymph is shifting because of the vibrations through the cochlear window. So we will say the perilymph is shifting up, and this shifting within the perilymph is actually transferred to the organ of Corti, and it causes the basilar membrane to shift as well. The basilar membrane houses the hair cells, which can then press up against the tectorial membrane. So you can see these little hair fibers, the cilia, pressing up against the tectorial membrane. And so if this basilar membrane is shifting, then these hair cells are going to bend against the tectorial membrane. The bending of the hair cells causes cranial nerve 8 to fire, specifically the auditory part of it. So this is a very significant point. This is where sound waves actually become electrical stimulation of an actual nerve. So it is at this point that cranial nerve 8 is stimulated. Now this is actually how a cochlear implant works. They cause electrical stimulation of the auditory nerve because the structures within the external ear and the middle ear are dysfunctional. So the cochlear implant will just skip these two portions of the ear that are responsible for conducting the sound waves and vibrations and then just directly stimulate the cochlea, the inner ear. In other words, the sensory portion of the ear. So now we know that cranial nerve 8 is stimulated. We can pull up a new slide to see what happens next. On the right is figure 8.35 from your text, and it shows a posterior view of the brainstem. On the left is figure 8.21, showing a cross-section of the medulla, which was discussed in section 3 of this chapter. So the cranial nerve 8 fibers will travel into the pons to the nucleus. Then the nucleus will then send up fibers through the lateral lemniscus. Now, knowing where the lateral lemniscus is located on a cross-section is not going to be super helpful for step 1 purposes. What will be helpful is knowing that the fibers from the nucleus of cranial nerve 8 go to both the superior olivary nucleus on the ipsilateral and the contralateral side. The superior olivary nucleus, much like the inferior olivary nucleus, is located within the pons and the medulla, which you can see here. Just to clarify, the inferior olivary nucleus is a prominent feature of the medulla, making it very important to recognize when viewing a cross-section of the medulla. Now, on the other hand, the superior olivary nucleus, which actually receives stimulus from the auditory pathway we're discussing, is not very prominent and therefore not important to identify on a cross-section. Now, fibers from this right cranial nerve 8 nucleus will then travel to the midbrain to the ipsilateral olivary colliculus, as we can see labeled here. And the cranial nerve 8 nucleus will also send fibers to the contralateral inferior colliculus. So the point is that signals from the right ear will travel to both sides of the brainstem. And same goes for the left, if we were to draw the pathway of cranial nerve 8 from the left ear. In other words, there's so much crossover within the brainstem. Therefore, if you damage the auditory pathway within the brainstem, for example with an ACA stroke, and just on the left side, you will get left-sided hearing loss and right-sided hearing loss. Whereas if you cause damage to just the cranial nerve, for example on this right side, you will only get right-sided hearing loss. So brainstem lesions on either side will cause bilateral hearing loss. But peripheral lesions, just damaging the cranial nerve, will cause unilateral hearing loss. So now let's talk about tonotopy and hearing loss. So to understand tonotopy, just know that sounds will produce vibrations of a certain frequency. Now each frequency is associated with a specific part along the cochlea. For example, the base of the cochlea is responsible for high frequency, and it's this high frequency that's lost in noise-induced hearing loss and presbycusis, or hearing loss of old age. Conversely, the helocotrema, or the apex of the cochlea, is responsible for the low frequencies. So let's draw this out. So here on the left is figure 8.33, which we discussed earlier in this lecture. And as you can see, here's the cochlea, and if we straightened it out, we would get figure 8.36 on the right. So this wide portion of the cochlea closest to the oval window is actually the same part as over here, the base on this left image. Now on the right image, the apex right here corresponds to the apex right here. I just want to clarify so you can understand what we're looking at. So the premise of tonotopy is that high frequencies are here at the base and the lower frequencies are here at the apex. Noise-induced hearing loss primarily affects the high frequencies first, damaging the cilia within the organ of Corti. This makes sense because as sound enters the cochlea from the oval window, it will reach the base first before it reaches the apex. So it'll cause more damage to these high frequencies. So now let's do a question. Let's say there's a 70-year-old male factory worker who complains of hearing loss. What part of the cochlea is likely responsible for this loss, the base or the apex? Now what is being described here is noise-induced hearing loss. Recall that noise-induced hearing loss damages the base first, so in answer to our question, the base is likely responsible for the hearing loss. If we were to take the question a step further, we could ask if he has lost the ability to hear low frequencies or high frequencies. Recall from the previous slide that high frequencies are associated with the base of the cochlea. So damage to the cilia in the organ of Corti near the base would diminish his ability to hear at high frequencies. So we would suspect that he would have high frequency hearing loss. Now let's talk about the Rene test. This is a hearing test, and it's performed by taking a tuning fork and placing it near but not touching the ear. So the sound is just traveling through the air. The other portion of the test is where you take the tuning fork and place it on a bony area surrounding the ear. So sound is transferred through the skull. And what you get is an air to bone ratio. So when the tuning fork produced louder noise to the patient when it was not touching the bone, in other words, it was just in free air, then that patient has normal hearing. But this can also be the case if the patient has sensory neural hearing loss, in other words, damage to the inner ear. However, if the patient says that they were able to hear the sound better when the tuning fork was placed against their skull, then that would mean that the bone is louder than the air. And this implicates conductive hearing loss. In other words, the outer or middle ear is damaged. Now let's talk about the Weber test. So now the Weber test is taking that same tuning fork and placing it on the top of the skull. And this will localize the hearing loss to the affected ear. So that's very important. So if the patient says that they can hear in the right and the left ear equally, then that's normal. However, if they say that they can hear in the right ear better than the left, then you think, oh, that means they have left-sided hearing loss because they could not hear as well in that left side. And then just the opposite, if they say that they can hear in the left more than the right, that means they have right-sided hearing loss. So now let's do some examples. So a patient describes a muffling of sound in the right ear following a boating trip. Upon physical exam, there appears to be water lateral to the eardrum. What would be the results of the Rene hearing test? So what is being described here is a patient who has water lateral to the eardrum, so water within the external ear. So here's figure 8.33, which we discussed earlier. Now if water is in the external ear, as I'm drawing with this blue line, then we just need to determine what type of hearing loss this is. Is it conductive hearing loss, or is it sensory neural hearing loss? We'll recall from previously in our lecture that conductive hearing loss is anything that prevents sound from getting to the cochlea, so any blockage of the outer or middle ear. So we can clearly see that this patient has blockage of the outer ear, so this patient likely has conductive hearing loss. In the Rene test, if the patient has conductive hearing loss, the patient would say the sound is louder when the tuning fork is placed on the skull, because the tuning fork is able to transmit the sound through the skull to the cochlea, essentially bypassing the middle and outer ear. So the result of the Rene test would be that in this right ear, the bone conduction would be greater than the air conduction. So to review, if a patient has anything disrupting the outer or middle ear, then they will have conductive hearing loss. So the Rene test would produce results that would show that the bone conduction is louder than simply air conduction. Now let's talk about the vestibular system. Now the vestibular system is quite simple in that it maintains balance. And it's composed of 3 semicircular canals as well as the utricle and the saccule. Now these semicircular canals are filled with endolymph, and there are hair cells with cilia within the endolymph. So vestibular transduction occurs when the cilia of the hair cells move against the endolymph. This will cause vestibular fibers to send signals to the vestibular nerve in the pons. So let's draw this out. So here is figure 8.33 from your text. So now we will focus on just the vestibular system right there. We mentioned that the vestibular system is composed of the 3 semicircular canals, as well as the utricle and the saccule. Now the utricle and saccule are in this region, but what you really need is a very basic understanding of just the semicircular canals. So here's figure 8.37, showing 1 semicircular canal. So each canal is filled with endolymph, represented with this blue. At the base of each canal is a cupula with hair cells and hair cell filaments, which you can see there. So when a person moves, the canal moves, and so the endolymph will shift, represented by these arrows. When the endolymph shifts like this, these hair cell filaments will be stimulated, and it will cause firing of the vestibular nerve. So what you need to know for step 1 is that when this system is messed up, for example, if you mess up the endolymph, then you're going to get vertigo. So an example is benign paroxysmal positional vertigo, which is caused by bone-like calcium floating around in the endolymph. The endolymph can also be disturbed in Meniere's disease. Now, Meniere's disease is not fully understood, but it is postulated that it causes vertigo by having excess potassium within the endolymph. The point is that if you mess up the endolymph, the patient will get dizzy. More specifically, they will have vertigo. Now let's talk about the vestibular ocular reflex. Now the purpose of the vestibular ocular reflex is to maintain an image in the center of the retina. So, for example, as the head turns to the left, the cortex, the frontal cortex, specifically the frontal eye field, will be stimulated. And this will induce the fast phase, which will also induce nystagmus. So the eyes will move left. Now, turning the head to the left will also cause firing of the left vestibular system, and this will initiate the vestibular ocular reflex, which will lead to the slow phase, or eyes moving in the opposite direction, which in this case is the right. So if the patient is unconscious, there will be no cortical input, which means the cortex will not be stimulated, so there will be no fast phase and no nystagmus. And if the brainstem is damaged, then the vestibular system will not function, so there will be no vestibular ocular reflex. So in other words, no slow phase. So let's draw this out. So here's figure 8.38 from your text showing the vestibular ocular reflex. So as you can see, the head is turning to the left. This turning of the head will stimulate the right frontal eye field, causing both eyes to quickly move to the left, which is this fast phase. Now this fast phase is the normal conjugate gaze that occurs when the right frontal eye fields cause the stimulation. We discussed this in the ophthalmology section using figure 8.45. Don't get wrapped up in that now. I just want you to recognize that the fast phase is initiated by the frontal cortex, which means that the patient must be conscious. So if the patient is unconscious, you will not see the fast phase, and that patient will not demonstrate nystagmus. Now, whenever you think of nystagmus in this particular process, associate it with the fast phase. Now, we will come back to the idea of nystagmus in a moment. As we just stated, as the head turns left, the right frontal cortex is stimulated, causing the eyes to quickly move in the same direction, so to the left. At the same time, as the head is turning left, the semicircular canals on the left will increase their firing, which we have labeled down here. So just remember that where the head turns, that same side will have a stimulated vestibular system. So in this case, the head turns left, so the semicircular canals on the left side will increase firing of the vestibular nerve. So that increased firing will cause the vestibular nerve to be activated, so the vestibular nucleus in the pons will be stimulated, particularly the left pons. It will then stimulate the right abducens nucleus, which will then stimulate the right lateral rectus muscle. Now the left vestibular nucleus will also stimulate the left oculomotor nucleus, which is in the midbrain, and this will then stimulate the left medial rectus muscle. So because of the increased firing of the semicircular canals in the left vestibular system, the vestibular ocular reflex will be stimulated, causing the eyes to shift to the right. This is the slow phase, as we've labeled here. Now, in order for the vestibular ocular reflex to function, or the slow phase to function, the patient requires an intact brainstem, because as you can see, we've used both the midbrain and the pons. This is useful to know because if a patient is unconscious or in a coma, you can tell if the brainstem is intact by using caloric stimulation, which is essentially squirting warm water into the ear. In this case, to keep things consistent, we will say that the warm water is being placed in the left ear, as we've labeled here. Now this caloric stimulation of the left ear will increase the firing of the left vestibular system, which means the brainstem thinks that the head is turning to the left. Now the patient is unconscious, so we don't expect the fast phase, and therefore we don't expect nystagmus. So we can ignore this in this unconscious patient, because it does not apply. However, we should still see the eyes move to the opposite side, or the right side in this instance. Now if the vestibular ocular reflex is elicited, and the patient does in fact have eyes that move in the opposite direction, or to the right, then that means the brainstem is intact. However, if this slow phase, or the vestibular ocular reflex, is not elicited, then that indicates that there is brainstem damage. And this is a bad sign in a comatose patient. Now let's do a quick question to apply this knowledge. So let's say there's a female patient who is unconscious following a car wreck. The medics on site are able to elicit a normal pupillary light reflex, indicating proper brainstem function. If caloric stimulation with warm water was performed in the right ear, how would the patient's eyes respond? So we have an unconscious patient after a car wreck. Now the medic on site determines that the pupillary light reflex is functional, which, as we've stated, means that the brainstem is functional. Now this is a good sign. Now what happens after the initiation of the caloric stimulation with warm water in the right ear? If we look at figure 8.38 again, we can walk through this. So if there's warm water in the right ear, then the brain is going to think that the head is turning to the right. And this means that the vestibular system, the vestibular ocular reflex, thinks that the patient is moving to the right, which means that the slow phase would occur to the left, meaning the eyes would shift to the left. And of course they're unconscious, so the fast phase is not present. Now would the patient get nystagmus? Nope. If the fast phase is not elicited, then there would be no nystagmus. So clinically, with this patient, with this caloric stimulation, the slow phase would be elicited and the eyes would move to the left. So just to review, the vestibular ocular reflex maintains the image in the center of the retina so that as the patient's moving, they can continually see everything that they need to in a way that's not making them super dizzy. And to remember that when the head turns to the left, then the cortex will be stimulated and the eyes will move in the same direction. And this is the fast phase, and associate that with nystagmus. And also the head turning to the left would cause the slow phase to move the eyes to the right. And if a patient's unconscious, that means there's no cortical input, so there's no fast phase or nystagmus. And if there's brainstem damage, there's going to be no vestibular ocular reflex, so there will be no slow phase. And that concludes this section.